Presented. Our next one, Dr. Brose from University of Pennsylvania, to give us some ideas about redifferentiation, potential benefits, and pitfalls. Marcia.
Okay, thank you. So I have a couple of disclaimers. First of all, to say that I'm one of the TKI researchers that does not actually research this area. So I give all of the credit to the background material that Lori provided me and most of the slides that actually Alan Ho gave me. So I'm going to channel the two of them and give an outsider's perspective of the field and hopefully not screw it up. So my disclosures are the following. I'm hopelessly conflicted. And so now what we're going to be talking about a little bit is a problem that most of us deal with in the clinic, which is the fact that there is a subgroup of patients that instead of having RAI Avid disease, eventually over time lose the ability to take up iodine and no longer become really candidates for RAI therapy and therefore not even curable at that point. And we also know that this coincides with usually uptake on FDG scans. So the data that goes behind this slide actually goes back at least 10 years to data that Jim Fagan had developed at Sloan Kettering, where he really looked and saw that with, among others, that with the dedifferentiation, you had low sodium iodine symporters as well as other proteins that trap iodine inside the cells. And he actually did some beautiful work, as I said, over 10 years ago, that really where he screened different sorts of inhibitors that would inhibit the MAP kinase pathway to see whether or not he could change this in cell culture, and was able to really show that if you can inhibit MAP kinase activity, you could end up with a sort of a redifferentiated phenotype in the lab. And because of that, this led to the hope that if we if we actually did this in patients, that we might be able to increase the iodine uptake to a point where we could get people back into the curative range from maybe even just palliative. Furthermore, when he did that screen of he had multiple drugs available to him. At that time, solumetinib was the winner as far as which ones inhibited the MAP kinase pathway the best. It's a MEK inhibitor. It's highly selective, and it inhibits in vitro as well as now we know in vivo. And this was the first proof, one of the first proof of principles was where they used I-124 PET to show basically that when you took a patient and you gave them solumetinib, that you could actually increase the uptake of radioactive iodine. So that was the toolbox that they were going to be basing this on. And so then the question was, how do you do a pilot about this? And this was a pilot that I actually got to comment on back 10 years ago when it was first presented at ASCO, which was a protocol that a pilot was put together by the whole team at Sloan Kettering on doing exactly this. So what they did was they took patients who had RAI refractory disease and did a PET scan, I-124 PET at the beginning, just to confirm that the index lesion, they had an index lesion that did not take up RAI on diagnostic scan and also had not for 2 years prior to enrollment. And it had not recently responded to a treatment of radioactive iodine. And also that it was a PET positive lesion. So all of the things that we know go towards something that a lesion that would not be amenable to radioactive iodine. And then the protocol then took the patients and put them on solumetinib for a 2 to 4 week period, mostly 3 to 4 weeks, where they had twice a day full dose of the drug, and then they were given recombinant TSH and given again a dose of iodine to see what was the iodine and what was the difference from the baseline. So they had actually a direct comparator here to say, is this increasing iodine uptake in these patients? And then based on that, if there was an adequate response, they just discontinued the solumetinib and went on to other sorts of therapies. But if there was a positive response, there was first a decision about whether or not the amount of uptake increase was clinically significant. In other words, enough to actually justify treatment with radioactive iodine. And if so, they were given radioactive iodine and then followed with scans. And I see Mike nodding, so I'm really relieved that I've gotten it right so far. I'm sure he'll let me know when I screw up, which is great. I count on him for that. So anyway, and I'm having trouble now. I went too far. So some of the first data is here, which is really exciting. You have a patient who has a BRAF inhibitor who actually had RAI basically non-detectable at baseline, and you can see here this beautiful increase both in the neck and also in the lungs following solumetinib. So this is sort of, again, a proof of principle that this did seem to absolutely make a difference. And I would say also very exciting, NRAS mutant patients. Now, we all know, I personally hate NRAS mutant patients, whether they are medullary or differentiated. They are the headache that is in my practice, and most importantly, the people who do the worst. And so it's a really difficult disease, and happily here you see really nice increase. This is the before up here, and then the after, showing again nice increase in uptake in this patient's disease. So what do we have? So out of 20 total patients, 12 were found to actually have uptake increased on the second scan. And of those, 8 of them were deemed to be candidates for another round of radioactive iodine, which they were given. So interestingly, if you look at across the different genotypes, you have BRAF mutants, NRAS mutants, and wild type. And what you see here was interesting is that you had increase in 4 out of 9 of the BRAF, but only 1 of them was felt to have enough of an increase to make it worthwhile in treating them again with radioactive iodine. Whereas here with the RAS mutations, you had 5 out of 5 where they had uptake, and it was a good amount of uptake thought to be worth treatment, and sort of an intermediate response in the wild type patients. So this was a very exciting result, and this was even more exciting. If you look here, you see out of those 8 patients who were treated, all of them seemed to get a decrease in the size of their tumors, with 5 of them getting actual partial responses. So this was an exciting result. Of course, for a pilot, it was just extremely, I think this was really what developed a whole new field, an interest in treating patients with radioactive iodine and see if we can improve their overall outcome. The interesting thing here, again, if you look, look at all the partial responses. 4 out of the 5 of them were the NRAS patients, and even this response that didn't, it probably was a large response and then shrunk back a bit, and so it wasn't actually confirmed on the second scan, was an NRAS mutation. Now, for context, I didn't put the data up here, but people should know that Ezra Cohen at the same time was doing a study in DTC with solumetinib as a single agent. And while that study was negative for hitting its primary endpoints, interesting data from that showed that NRAS was maybe a subgroup of patients that looked like it was doing better with solumetinib alone. So what is a little bit out there is to know how much of this result would have been due to solumetinib alone versus RAI. I think this is deeper than we would have seen on the study, but it is true that solumetinib does seem to work better on NRAS even without the radioactive iodine. And what we also don't know is what are the real durations of these responses, and that's some more information that's going to come out, I think, in additional studies. From the pilot study, we see that the MEK inhibitor solumetinib really significantly enhances RAI incorporation efficacy in a subset of tumors, and that RAS mutant patients particularly may be susceptible to this strategy, and again, highlighting that this is a very difficult patient population to treat, and if we could even make any inroad with them whatsoever, this would be a huge impact for their care. And that we still have to factor in that we really don't know in this study exactly how much of the impact of the MEK inhibition alone contributed to those responses. And I really would encourage people in the future, hopefully, to get some studies where we can maybe randomize patients to the MEK inhibitor or a placebo to really flesh out what that contribution is. There was one cautionary tale in this study, was that one of the patients who were treated, so one of the 8 patients, did subsequently end up having leukemia, first with myelodysplastic syndrome and leukemia. And I will point out it was 51 weeks later. And so, some people say, oh, it's 51 weeks later, you need to worry about it. But of course, this is radioactivity. We're not talking about, usually studies that we do have toxicities where we follow them only 30 days after they're off study. But with the radioactivity, the fact that these patients had radioactivity to start with, we do have to remember to keep some sort of a safety profile in the future studies where we look, because if we're also increasing radioactive iodine in the bone, that could lead to problems. So it's my one little caution to people when we're doing this in the future, and hopefully for future trial designs. So where are we now? We're basically now with with a multitude of other agents now that can target this pathway and answer some additional questions. So ITOG, soon after the study opened, the other study data came out, started a study where they randomized patients who had RAI Avid, so still had some avidity in their tumors, to see whether or not solumetinib could improve the uptake with radioactive iodine, and again, the overall benefit, with the primary endpoint being the response rate at 6 months, with also, of course, looking at other secondary endpoints being best overall response, progression-free survival. This study is currently still enrolling. And so please send your patients to any of the nearby ITOG sites. I am going to be if nothing else that you get out of this, I think that everybody should go on study. That's my big takeaway from my talk, my outsider's view of this. So solumetinib here is being given again with recombinant TSH suppression before the radioactive iodine, and this is the trial design right now for the ITOG study. Another study that was another area to look at. So now we've looked at this this is sort of the overall view of where you can actually use radioactive iodine. And we know that, of course, we can use it after thyroidectomy for ablation and adjuvant therapy. This is the area I'd say that the ITOG study is focusing on, where we have sort of still a little bit of Avid disease. And here, traditionally, no role for RAI, but we just talked about the fact that maybe there is a future for the RAS mutant, maybe a little bit for the BRAF mutant. So the question then becomes, what is the appropriate drug for each tumor type? Can we map, and so can we start to flesh these out into separate trials? Can the MAP kinase pathway inhibition be optimized? And then can other hypotheses be validated? Maybe we can do better patient selection to really find which are those patients that are going to benefit and really be a home run for this therapy. So one of the trials that came out of this was then looking back at this in this setting, where we have the adjuvant and remnant ablation, and that was the Astra study. So the Astra study was enrolled 233 patients from 2013 to 2018. It was really widely open across multiple countries. It was a phase 3 study where it randomized patients to either solumetinib and RAI or just RAI alone in patients who were deemed to be high risk. And the high risk was deemed on multiple factors, either the size of the tumor, the multiple number of lymph nodes that were involved. So these were patients that at the time of their original surgery were felt to have, I think it was at least a 20 or 30% chance of recurring early on. And the question was, if we gave solumetinib and hopefully improved the radioactive iodine therapy at the time, would it actually result in a better outcome? And so the primary endpoint for this was the complete remission rate at 18 months following radioactive iodine. And Alan, I think, presented this data at the ATA in the fall, and unfortunately, it was disappointing in that the p-value was not significant in the overall. The odds ratio was 1.07. And then when they looked at the BRAF NRAS subgroup, again, it was not necessarily, it was a negative study. So it was a disappointment, but I will say, remember, this was a double leap. You know, Alan's study was in a different setting of patients, and a different setting of patients, and we basically took 2 steps. So I don't think this is necessarily something to, I mean, obviously I don't think we should be doing this now in patients without being in a context of a clinical trial with additional study design. And I think there's a lot of effort right now to really mine this data to try to figure out, are there certain patients specifically that this was working on? Are there biomarkers for the people who did seem to get a little bit of a benefit, so that can inform future studies? But at this point, I wouldn't just do this on all the patients personally, because I think we're not necessarily helping them. And what's more, while it may only have had a 5% SAE rate, they did have some significant toxicities, either gastric hemorrhage, hypersensitivity, cellulitis, hypercalcemia, syncope, and dermatitis. So these are not risks that I would want to give people without evidence, without good data to say that they're benefiting. So at this point, I would say, caution that in this setting, I would recommend everybody to a clinical trial. I think I just said everything on the slide, so I'm going to zip ahead to help Mike out. So then we can go back to the NRAS question, right? So maybe we can start doing studies where we target specifically the RAS patients, and even look at whether or not there might be other sorts of things that we can do that have even stronger inhibition, and take the people who are maybe moderately improved, the RET PTC and the wild type patients, and say, well, maybe if we made their MEK inhibition a little bit stronger, could we improve that group? And we could do that either by doing different MEK inhibition, so it's something like trametinib, or like what is also being studied, which is in the BRAF. We had vemurafenib, which was done by, I think, Laura Dunn at Sloan Kettering, but also Lori has dabrafenib going on at MGH, really to try to get at, if we really focus on these certain pathways and really do a good job at shutting them down, and maybe we can start to actually translate what looks like a promising pilot data into really clinical utility. I think that we just don't have exactly the right drug yet or exactly the right setting, but I think we're getting close. And I'm hopeful that we'll get there, or that they'll get there, because I'm counting on them to write these really great trials, and hopefully we'll get the data soon. So what we do see here, though, is by going to in vemurafenib, we now have 4 out of 10, whereas with selumetinib, we only had 1 out of 10 that really benefited. MAP kinase output, this is with vemurafenib also showing increase again. Just look here on the right, you have increase compared to the left, showing that's definitely working. So in general, we have multiple trials. I apologize, Lori, I forgot to put your MGH dabrafenib study on here, but we have MGH doing studies. We have Sophie at Gustave Roussy. John Wadsworth is also doing it in the UK. In other words, where you live is probably no excuse for not putting somebody on one of these trials. Please enroll your patients, because I think this is very hopeful, but unless we get patients on the study, we won't be able to get this moving fast enough going forward. So the final slide, so the goals now are to develop and optimize the therapeutic strategies by the pathway inhibition, validating the hypothesis and minimizing the toxicities, making sure that the studies follow longer-term toxicities, as I said, defining the appropriate clinical settings, and exploring predictive markers, so that maybe we can select the patients ahead of time that will benefit the most. And that's it. Thank you very much.
Special thank you to Marcia and Lori for covering a lot of ground and doing it in quick order.